Welcome to COVID-19, the Orthopaedic Response. This is a production of the DOCSF team in partnership with UCSF. I'm your host, Shauna Butler, and I'm so thrilled to have us joined by the American Academy of Orthopedic Surgeons. They've been part of helping us be a global convener to address these rapid changes that we've experienced and dramatic changes to healthcare and our patients and our practices and our communities as a result of the coronavirus. And we're really grateful to have a global audience that's joined us for the discussions and to help us learn more about the problems that we're facing, the solutions that we're developing. And I'm really thrilled that I can welcome Carlin Center to this session. So Carlin is an interesting intersection, being in primary care sports and also a member of the Department of Orthopedics and Internal Medicine at UCSF, a professor there. And really one of the early pioneers in video visits, e-consults, and from what I understand, you are pretty darn passionate about using these technologies for medical education.
Yeah, thanks, Shauna. It's great to be here. I'm really excited to talk about video visits today. And like you said, I'm really interested in technology and all of its applications in medicine, particularly to help patient care, of course, as well as medical education. Go ahead.
Mm-hmm.
Yeah, so I think the point of my talk today is to really focus on video visits and to talk about really what the keys are to a successful video visit, particularly in the orthopedic setting. Like you said, I'm a primary care sports medicine doctor, so I practice some primary care and some primary care sports medicine. And so today we'll focus on the use of video visits in orthopedics and particularly in sports medicine.
Yeah, well, and again, the reason we wanted to bring this in is that we have just seen such a dramatic shift that we've had to adjust to all of a sudden. So many people are moving their practices to the virtual space. So we wanted you to take this opportunity to really give us some very detailed nuts and bolts of how we can make this happen. So how about if I get your presentation up there and let you take it away?
All right, great, thank you. So we'll talk about take-home points first and go into the details and then answer any questions. So I think there are about 8 really key take-home points about how to run a successful video visit. So you want to use both an electronic health record and a video visit platform. You should be in a quiet, professional space. Ideally, you would have excellent internet, big monitors, a webcam, speaker, and a headset with mic. And we'll talk about finding the best workflow for your setting. It's important to provide patient instructions and to document using appropriate telehealth consent verbiage and time spent. The billing is very straightforward, and we'll touch on that. It's standard E&M outpatient coding. And then, what I think is really exciting is to think about what's the best use of video visits in orthopedics. And I think this is kind of an open question at this point. So I wanted to present to you what's been going on at UCSF Health. This is data over the past month of ambulatory visits, weekdays, Monday through Friday at UCSF Health. And you can see over the last month, a declining number of the blue visits, which are non-video visits, and an increasing number of the green visits, which are the video visit visits, particularly in March. So what happened on March 11th is we were asked by UCSF Health and the community to convert visits to video when possible for patients high risk for COVID-19. And in the city and county of San Francisco on March 17th, we had the shelter-in-place mandate. And after that, we were converting all possible visits to video. And then looking in particular at the Department of Orthopedics, you can see here that video visit uptake has been throughout the department. So this is data from March 17th to March 27th. Visits in blue, non-video visits, and in green, video visits. And you can see uptake across the orthopedic specialties with video visits. Again, our first 2 weeks of shelter in place. So the keys to video visits are first, I think, to have an electronic health record so that you can access the patient information really from anywhere. It's also helpful to have the EHR with a patient portal so that the patient can communicate with you that way. You can send the video visit training that way. And then secondarily, and next to the EHR, you want to have your video visit platform. Thinking about the space that you're in is helpful. So you can see on the left of this slide is my, so-called COVID-19 office. And on the right, I've put in a picture for my virtual background, and that's a picture of my usual clinic room here in San Francisco. So the nice thing, if you have a solid, painted wall, you can actually slip in a photograph and make a pretty convincing professional virtual background. Equipment-wise, so must-haves, excellent internet, a webcam, speaker, and a phone in case the video visit fails. And nice to have a headset with a mic and a really big monitor so you can see everything. You can see in this picture some different setups, and as you can see, some of these are like more ergonomically appropriate than others, but you get the idea that you can really use different configurations of laptops and desktops and tablets and phones, kind of whatever you have. So to think about the workflow, so how does this work actually in your practice? There are really, I think, two workflows you could consider. The first is a provider-only workflow. So this works well when the visits are longer and overall lower volume. This would be the provider just running the clinic on their own. And what this does is it saves space because the provider can do this from anywhere. It does not have to be on campus or in the clinic. And this also saves staff time because they are unassisted. Alternatively, video visits can also be run with the help of a medical assistant or an athletic trainer. And this works nicely when the visits are back-to-back and when there's a higher volume. So the assistant would call the patient ahead and get the patient set up, make sure that they are in the video visit portal. In our case, we use Zoom, and so the athletic trainer would call the patient, make sure that the patient is in my Zoom waiting room, and then the athletic trainer would reconcile the meds, reconcile the allergies, double check the chief complaint, and put that all in the chart the same way that they would if the patient were seeing me in clinic. This can be done all remote, and we are doing that at this point at UCSF Health, all our video visits remote, even with assistance. And that works pretty well. You just have to, again, have a phone. It helps to be able to text or somehow communicate with your assistant. Patient awareness is another key. So we have a website, videovisit.ucsf.edu, that you can refer to see sort of what we tell the patients about setup and how to train them. This provides training so the patient can get the portal, the Zoom portal, up on their device. We also have brochures, and the patient gets phone reminders similar to how they would if they were coming in person. So they get a phone reminder 3 days and 1 day ahead of their video visit. And something we've changed recently to help facilitate uptake of video visits is to ask patients to activate their patient portal at the time that they enroll in the health system. And this is a subtle change from what we did before COVID-19, which is to say that before COVID-19, we would wait until those patients saw us in person, and then we would provide them with a handout with instructions for how to activate the portal. But these days, because we're really trying to keep everything virtual, and with telehealth, we ask patients to activate that online, and they can start their portal that way. Documentation, I thought I would walk you through a typical video visit documentation from my chart. So this is a patient visit example. And when I open this, we use Epic, which you see here. You can see I'm in the pre-charting mode. When I start the visit, the patient's been brought, I brought the patient in from my waiting room. I would click Start Visit, and then I would click Create Note. You can see in this case, I have some other buttons next to Create Note, and those are kind of speed buttons. You may have that on your Epic as well. And if you look closely, I have one that says Ortho Video Visit Follow-up, and that's what I would click to bring up this note template. And so I would encourage you, if you haven't already, to create some templates for video visits, because they're a little bit different, obviously, than face-to-face visits, and that will just save you time. And so this is my video visit template for a follow-up patient. I do include at the very top a patient consent. And this is just in case your assistant hasn't already discussed this with the patient. So it's important to make sure that the patient is okay with the fact that this will be billed to their insurance and that they may have a copay, the same as if they were seeing you in person. And also UCSF Health asks us to make sure that the patient is not recording the visit, because it's not permitted. So we go over those two things if they haven't already been reviewed. And then the other sort of administrative things to remember to do are to include a notation to alert billers and insurance that this was a telehealth visit or a video visit. So that's this first phrase, that you performed the consultation using real-time telehealth tools, etc. And then the second phrase that you see is probably one that, as a provider, you're familiar with, which is a time spent phrase. And I think in video visits, because you may not have as complex a physical exam, because the visit is going to largely be comprised of counseling, it's helpful to put a timestamp so that you can bill on time if you need to. All right, so billing and coding is the same as your usual outpatient E&M billing and coding. So your standard 99213 and 14 and 15. It's the same kind of structure, and then use the timestamp when appropriate. And the last key is really, which cases are best for video visits. And I put an asterisk because I think we really don't know. I think it's up to us to start using these widely and being flexible with the idea and seeing, how much physical exam can you really do through video, and asking your patient to participate and try some stuff on their own. So the video visits that I think have worked really well so far are sharing an image. So with Zoom or your video platform, by sharing your screen, you can share, say, an MRI or an X-ray with a patient and really teach them and walk through that together. So that's been very successful. Checking range of motion, particularly in the upper extremity, I think is very feasible. We've done concussion follow-up very successfully. Looking at balance in particular on video is very easy to do. And bone health, so taking care of patients with osteoporosis, looking at their labs, looking at their DEXA scans, talking about pharmacologic management, nutrition, all of that is easy to do using telehealth. All right, so I will remind you of our take-home points. So take-home points for really successful video visits: having an electronic health record and a video visit platform side by side. And I should say, when you do a image share, it's important that you have your video visit platform on the same computer as your EHR so that you can share screen. It's great to have a quiet professional space. And ideally, you would have excellent internet, big monitors, a webcam, a speaker, and a headset with a mic. And it's up to you to figure out your best workflow, whether you want to run it on your own as a provider or with an assistant, with a medical assistant or an athletic trainer. It's important to provide patient instructions so that the patients can get themselves set up ahead of time. Remember to document using a telehealth consent tagline and a time spent. Remember that billing is standard using outpatient E&M coding. And then sort of experiment about cases. I think we're all learning about what cases really work well. And with that, I will end. I really appreciate the opportunity to be here and your attention, and I look forward to your questions.
I was going to say, I really appreciate from the standpoint of just being there, really nuts and bolts. And I'll let you go ahead and use my setup if you want to give a critique about what are we supposed to do to make it look professional and warm and welcoming. So yeah, I was going to say, I'm thinking that you had mentioned that you were invited by the orthopedic department to help all of the department really move over to virtual video. Do you have a consult with somebody and give them a dry run through to figure out how you would run a video visit?
Yeah, so it's luckily at UCSF, we've been doing video visits for about 5 years, and we have a great telehealth resource center that has a lot of toolkits and things for providers, which I help refer to and let providers know, hey, these are the steps you would do. Here's how you get a Zoom account. Here's how you download Zoom. Here's how you open it up when you start your video visit, sort of all those nuts and bolts. And I do think, when you're getting started with this, like the first one, it's really great to have someone at your elbow to kind of help you out, because, when you're trying to be in a busy clinic and do patient care, your mind should be focused on clinical decision-making and not on how to do technology. So, I think if possible, it's awesome to have someone there with you, or, on the phone with you or something, to kind of troubleshoot things. And it's also really quite possible to do a dry run if you have someone willing to Zoom conference with you. You don't have to do your practice with your patient. You can always do a dress rehearsal, with a family member.
I was just going to say, this is when you call your kids and say, okay, mom needs some help with figuring out how to do this. And usually they're the ones that are your tech consultants,
Yes. Yeah. I mean, these days with a lot of families are home together. And so I've had a lot of patients have a lot of success as this being a family project.
Yeah. I was going to say, everybody needs a 10-year-old. Everybody, rent a 10-year-old type of thing. So we've got a couple of really great questions. And one of them was about Zoom. It's been noted, this is from Michael Baer, and he was asking, he said, Zoom's been noted by several news channels to have reportedly poor security. Do you have a take on extra measures to assure the HIPAA compliance or PHI security?
Yeah, that's a great question. And I think very topical. So we actually just got an update from UCSF Health on this today, and a couple recommendations. So one is you can set up Zoom meetings with a password. So the recommendation is if the meeting needs to be highly private and you're worried about the security of your Zoom, to make it password protected. A second is when you have a Zoom account, you have your own meeting ID. So on Carlin Center, I have it's like my office, right? So the meeting ID is as if that's always my office, and it's sort of always open. Like the minute I press start meeting, I open the office door, and whoever has that number might be in the waiting room. So another thing to do is to make sure you have a waiting room set up, because you only then would admit people to your office from the waiting room that are the right people. The third thing to think about is that you can also schedule a meeting, and that will generate a random meeting ID. So if for some reason my personal meeting ID gets compromised and like it's on a billboard or something and everyone has it, I would then need to schedule a meeting, and that would generate a random number, and that way it would be private. So there's a few strategies that can be used if your number has gotten compromised.
Okay. And in thinking about, as we move to the video visits, there are a couple of things just that are different. We're used to, in the in-person visits, people are coming to our space. We control that. We get to put together what the waiting space looks like, what the exam room looks like. This can be a little bit invasive. You're coming into my personal home. And so first of all, are you meeting? I will say my years being a visiting home nurse, which I loved, it gave me an insight into somebody's life. So from the standpoint of being able to do an assessment or their fall risks, what is their bathroom setup look like? It gives me an insight into their hygiene, into their nutrition, into the family dynamics. I get to see, are their medications properly stored? So this is a really interesting opportunity with the video visits. And I would imagine, particularly in orthopedics, to take a look at, are you wearing shoes that make it easier for you to heal? Have you got clothing that allow you to get in and out of? I mean, so talk about the etiquette and then also the opportunity or the things where it is inhibiting people to visit with you.
Yeah, I mean, I think it has been it's been very fun to see patients at home with, in their garden, with their paintings, with their pets. These things are really cool, and patients have enjoyed showing me stuff, like their pets and things like that. So I imagine it's sort of like a home visit, though not as informative, of course, as sort of what you did as a visiting home nurse, but it takes you there a little bit, certainly more than them coming to your office. And I think it is a little invasive. It is, though, on their terms. I think people can allow you in or not, and either way is okay. As far as how they set up their screen. And sometimes family members participate, and sometimes it makes it easier for family members. So
Yeah.
I had a case this week, a patient whose parents wanted to participate as well. Parents are not in the same place as the patient, but very easy for us all to meet and see each other and hear each other well via a video visit. I think as far as like the patient satisfaction part of it, UCSF Health has been looking at patient satisfaction data since 2016, and it's overwhelmingly positive. So on pretty much every metric, video visits meet or exceed the patient satisfaction scores as of in-person visits. And patients call out what you would expect, right? So it's so much more efficient. It saves cost. It saves time, and they find it that that the communication is really good. So I think it's patients overall. It's overwhelmingly a patient satisfier.
Yeah, and while we're still on that etiquette piece, you mentioned the sensitive or the difficult conversation. You recently had a situation where you needed to prepare for that. So talk through what a good plan and a good strategy is for sensitive, difficult conversations that you might need to have with a patient using a video visit.
Yeah, I mean, I think that video visits are great in many ways. And then I think in medicine, there's nothing like seeing people in person. And so, when I anticipate that I may have to deliver bad news, my inclination and my preference would be to be able to see the patient in person. And typically I would set that up ahead of time. And I think, most of us would do that. So if you're anticipating that you're
why don't
going
we give
to,
that, the specific example around you had
yeah,
ordered
so,
it.
So in, I had a patient this week with a new breast mass, and we talked about, she's going to get testing done and how did she want the results? And, I asked her, did she want to come in and see me? Or did she want me to call her, or we could do video? And she said she wanted a phone call, and so she knows, whether it's good news or bad news, she'll be getting a phone call as soon as I get the results. And that way it's set up ahead of time. And I think just if setting patients up for anticipating, how you'll meet them where they are, on whatever terms.
Yeah. So just understand what the benefits are, but then also maybe what some of the limitations and the sensitivities are for a video visit. We've got several questions in here. So let me get to one of these. Richard Centauri wanted to know, and this is a really interesting one right now. Can you comment on the legal and the regulatory issues around physicians licensed in one state conducting a video visit with a patient in another state? And I'm imagining if you're licensed in both states, it's not an issue. But if you're not, so what's going on with regulations right now?
And it's a really good question. And this is really new information. So before COVID-19, we Californians, I'm a Californian, could only conduct video visits in the state of California because that's where I'm licensed. This has changed. So CMS issued new guidelines around this, and physicians can now conduct can practice telehealth across state lines. This is temporary, so I don't know what will happen post COVID-19, but for now, when conducting a video visit, your patient no longer has to be in the state in which you are licensed. I can see my college student athlete with a knee injury who has traveled home to Atlanta, but is still my patient. I am now licensed to take care of them during COVID-19, which has really helped, our practice, because so many people have, at least in San Francisco, we have a lot of kids who aren't here anymore. All of our college student athletes, many of them live out of state. And so that helps us continue our longitudinal care.
It's also the reverse is true, where we've had a lot of healthcare professionals who have had to relocate to another state, either to take care of an aging parent. So their practice, they've got all of their practice in one state, but they're in another one. And just to clarify on all of those, that also has been extended to nursing licenses. So if you've got a nurse practicing in your group,
cool.
There's the nurse compact licensure, which is there are more states that belong to that, but that was also one of the other things. So if you have a nurse practicing in your office, they also are able to participate in those cares. Nurse practitioners, that also has been something that it's still under review, but I'm sure that in this moment in time that we're going to be looking at that. So you need to think about that with your staff, because oftentimes pre-op care, post-op care, follow-up, we need to think about all the licensures in there. All right. So Christian Bentley was asking, sports medicine involves many provocative maneuvers for accurate diagnosis. How are you going to address that now and in the future?
Yeah. And that is probably why I love sports medicine, is that, I think there's a lot that can be done these days in medicine. It's sort of like, use the answer box. So like, you have heart failure, we're going to get an echo, or you have belly pain, we're going to ultrasound your liver. In sports medicine, you can say, hey, you have shoulder pain, I'm going to get an MRI, but you know what? That MRI is going to show like a lot of different things. And in the end, it still comes down to the history and the physical exam. And if you aren't really thinking carefully about your physical exam, then it's going to be tough. So I don't think there's an answer to that. I think right now in sports medicine, there are limitations to video visits around the careful laying of hands, and really figuring out with your patient what each exam maneuver means diagnostically. That is hard to carry out. I've tried this week and last week to do that with new patients via video to see what they can do on their own. But it is a limitation. I think, you can only get so far if you haven't examined the patient.
And how are you managing the physical exam where modesty is an issue? It's one thing when you're in person and we can do a lot of draping and gowning, and then also there are just moments of like, it's a license to touch. When you add a component of it being on camera, how are you managing those sensitive issues of modesty?
Yeah, I haven't run into too much of that, I think. And patients, also are pretty good at least as far as I've had to encounter it, sort of draping themselves and doing what seems appropriate. And with, say, a shoulder exam, my patients actually so far have been very prepared on video. I'm thinking about, the patients I saw today who were in tank tops and sports bras and things like that, are very modest and would be similar to what they would wear in the office.
So they've got that covered, but it might be something that you need to think about. Okay. Let's see. Pam Baruji is asking, how is a video visit appointment made? Who initiates the actual start of the video visit?
Let's see. So from a scheduling standpoint, a video visit, at least at UCSF Health, is scheduled on our clinic templates similar to a follow-up or a new patient visit. So it's an encounter type or a visit type in Epic. And the both the physician and the patient initiate it. Sort of depends on which workflow you're doing, but you might have, your medical assistant might call the patient 15 minutes ahead and onboard them and do a chart reconciliation. And then you would be in your Zoom office and you would see the patient in the waiting room once they were there. And then you would click admit from waiting room and they would join you in your office. And that's sort of how we roll. And then when the visit's done, the patient usually leaves, or you can actually move the patient back to the waiting room.
So one of the issues that's always been a challenge, I mean, you brought up the importance of having great screens, having good internet access. That's you on the provider side. How do you manage that on the patient side?
It can be challenging. I've definitely had patients attempting to do video visits in the car. That makes you a little nervous, and you try to convince them, like, yeah, let's.
Not while they're driving, I hope.
Yeah, no, I've seen that.
You've seen it all, right?
So, if it's not working, you have to do some troubleshooting about, what's going to work and what's not going to work. But again, these days, I mean, I think in the last 2 weeks, there has just been a really major change in people's capabilities and understanding about technology and meeting on video and what that means. I think my sense is that people are using it, socially, for exercise, for community. And that makes it all the easier as a physician because people understand what works.
Right. So I think so we're talking about the practice and the individual level. If we're going to be moving this more as an institution, as communities, as cities, and we want to rely on this, particularly when we're putting this in place where there's a mandatory order, you have to shelter in place, limit your physical, to essential visits. What do we need to be thinking about and encouraging at a system level to help make this something that, it's available to everybody, that we're making it, we're not increasing the disparities there? How, what can we do so that, because to your point, you've got a lot of your college athletes, and I'm thinking about these students right now who they don't really have any other place to go. They're kind of in this place of limbo. How can we, have you got some thoughts about how to mitigate some of the challenges that we're seeing?
Yeah, I think that, so video visits can, help with health disparities for sure. They can bring care to rural areas, and that has been studied and shown to be true in a number of different areas. So I think the VA does a phenomenal job of that, and maybe the most robust telehealth practice in the country. And certainly they have a depth of experience that probably exceeds every other health system in our country. Yeah. So, they've been doing it a long time with very cool technology, stethoscopes that broadcast and things like that. The model there is a little different. So the video visits that we do at UCSF Health, we do that straight to a patient's home. The model that the VA uses and other places use in more rural areas is that the patient actually comes to the VA, say in Eureka, California, and meets with a nurse there who then onboards the patient to their video platform, and the doctor's in San Francisco. And so that's a different model, and one that, and that's a strategy, I think, that works well when you have an area where maybe the internet bandwidth is not going to be good at everyone's home, and where maybe the technology is not going to be good at everyone's home. And that helps level the playing field so that you can bring telemedicine to people elsewhere. And, and I think it's interesting to think about in urban settings like San Francisco. I don't think we know if video visits or what sort of disparities video visits create. Or do they help break those down? I don't think we know. I think it's something we need to look at.
Well, you have been leading this curve, and so now everybody's catching up. So when we think about leading the curve, because of where you're positioned, what's the next horizon? I mean, this pandemic has given us an opportunity like, okay, let's everybody catch up to Carlin. So rather than catching up and keeping the level where it is, where do you want to go next? What do you think that we're positioned to do that we might not have done otherwise, given without having this unique moment? What can we
Yeah.
do next?
Yeah, I mean, I think it is a real opportunity for providers to look at their practice and say, well, this is interesting, and which of these patients actually needs to come in person, and which don't, and when they don't, would they actually prefer to see me on video? And they might, even without a pandemic. And I think in many cases that can be very successful. I'm thinking in my practice of patients with frozen shoulder, super successful follow-up visits over video, bone health, concussion, and you can imagine as well. I think I'm not an arthroplasty surgeon, but I think my sense is that an arthroplasty practice would be very successful over video, because I think you can achieve a lot reviewing radiographs and things like that. So I think in orthopedics, as long as the patient has up-to-date imaging and has had a relatively recent physical exam, you can do a lot of longitudinal care via video, even without a COVID-19.
Well, I think you are such an inspiration for helping us to adopt this, to be a lot more comfortable with it, to make it a lot more fun, to identify new opportunities, and to keep us safe. Because we are going into these uncharted territories, and you don't know what you don't know. So we're counting on you to help us learn and to be a leader in all of this. So thank you so much for taking the time to come in back and do this, and to really help us to see the magic of the video visits and how we can do this in new and interesting ways.
My pleasure. Thanks very much for the opportunity.
All right, guys. Thank you so much for joining us for the COVID-19 Orthopedic Response. It has been such a pleasure having this phenomenal audience joining us from all around the globe, looking at the problems, the solutions, and finding new accomplices, conspirators, and people who are inspiring us to do things in new and better ways. And you stay safe, stay home, stay connected.